Welcome to an episode number 45 of Editors in Conversation, which is our podcast for our journal Antimicrobial Agents and Chemotherapy. I am Cesar Arias. I'm the editor-in-chief of Antimicrobial Agents in Chemotherapy, and we are recording live today from Los Angeles, California in ASM Microbe 2025. So before we start this, I just want to make an announcement to everybody about our new antimicrobial resistant meeting. This is an effort between the American Society of Microbiology and the Infectious Disease Society of America, which are launching a new meeting that is going to put together the drug developers, scientists, pharmaceutical companies, clinicians, microbiologists in one place. The meeting is called IMARI, Interdisciplinary Meeting of Antimicrobial Resistance and Innovation, and it's going to take place in January 28th to the 30th in Las Vegas. So I hope to see you all there. For all the audience that listen to our podcast, you're welcome. This is the start of a new era in a forum that finally brings back the latest spirit that we had when everybody was together. So today we're going to talk about something really interesting, which is the concept of Cidal versus static antibiotics. These are concepts that we learn since we get trained. When, as physicians, we are trained to use certain drugs in certain conditions that are Cidal versus static. However, all these concepts are now very fluid. We are understanding much more what the effect of the antibiotics are in bacteria. But most importantly, the clinical impact of those terms may not be as profound as we were taught. And I think we need to revisit this. This podcast is sponsored by the American Society for Microbiology that publishes AAC. Don't forget to check our latest issue of AAC with really phenomenal papers on mechanism of resistance, pharmacology of antimicrobial agents, epidemiology of antimicrobial resistant infections. We have a section of challenging clinical cases of antimicrobial resistance and several others. And if you are a member of ASM, which I hope everybody who listens to us is a member, you get up to 50% discount in your papers fees for publishing in AAC. We really are excited about what's happening in the future with the journal and the new IMARI. So to discuss this wonderful topic, we have really a superstar in the field, a person who has written books about resistance, who has been a leader in this area, who is Dr. Brad Spellberg. Welcome to the program, who is the Chief Medical Officer of Los Angeles General Medical Center. And the objectives of this podcast is we are going to go and discuss this concept of Cidal as static. We're going to elaborate a little bit of the clinical impact of this concept and how people are changing the views on this. And then debate a little bit on what is this controversy of in the field of this? So Brad, let's start from the beginning. So, what is Cidal and what is static in your concept?
Well, if you ask most people, what they will say is Cidal means the antibiotic kills, and static means it inhibits its division, but it doesn't kill it. That's the intuitive definition. That is not the microbiological definition. If you look up the microbiological definition, the definition of a static antibiotic is one where the minimum bactericidal concentration is not more than fourfold above the minimum inhibitory concentration. And a static agent, the MBC, is more than fourfold above the MIC. And that's where the problems come in.
Yeah. Another interesting concept, actually, you know, AAC has definitions for static and Cidal, and that becomes related to killing curves. So really, in terms of you defining an antibiotic, you have to do a killing curve, which means you have to count bacteria at the time, and you define Cidal if you have 3 log or more decrease in the killing at 24 hours, not at 96 hours, not at 48 hours. Anything below that is not bactericidal. you can call it a static, but it's 3 logs. If it's 1.5 log, it's not going to make it. So you will call it a static in these definitions. And that is a definition that comes from the 70s. And this is an in vitro thing, right?
It comes from the 30s and 40s, actually. And that's the minimum bactericidal. That's how you identify the minimum bactericidal concentration, the MBC. The thing is that almost all antibiotics can get you to that level if you use a absurdly high concentration. And so clinically, people have tried this MBC-MIC ratio to say, yes, I understand doxycycline can get you to an MBC, but the concentration used is so astronomically high, it's still a static antibiotic. The MBC is more than 4-fold above the MIC. So yes, the MBC definition goes back to the original penicillin studies in the 30s and 40s. But there's no science, as you're saying. Why is it a 1,000-fold reduction? Why is it at 24 hours? Why does it have to be a 4-fold ratio of MBC to MIC? Why should there be any relationship between the MBC and the MIC? These are all arbitrary decisions, not grounded in clinical outcomes.
Yeah, this is a very important point. And also, it depends on the conditions that you do the test. Let's say a drug like daptomycin that requires calcium for killing, the calcium concentration or the media that you're going to use is going to determine if this is really a bacteriostatic effect or bactericidal effect. So, and another interesting concept that are being percolated in the last 10 years that are, is this concept of persistence, tolerance, right? And there are others less used concept in the mycobacterial world that we've heard and we've seen published. So what do you think about that? The persistent definition people think is that you cannot kill bacteria, but you cannot identify any mechanisms of any genetic change for what that happens. What do you think about this concept?
I mean, I think that the definition of a non-replicating persister, which has entered a state of dormancy, which is maintained via mRNA transcription, I think is a real phenomenon and explains late relapses from tuberculosis or osteomyelitis. Interestingly, the first use of the term bacteriostasis that I could find in literature was from 1923, assessing colored dyes, gentian, violet, and stuff, that would lead to some persisters that would relapse. And so they called it stasis rather than Cidal. That is not what modern people mean by stasis and Cidal, right? Because that happens even if you use a bactericidal antibiotic. Betalactams and stuff, you'll still end up with persisters that they can't kill. So I think non-replicating persisters is a real phenomenon. The challenge is the terms bacteriostatic and bactericidal are misleading, and we need to stop using them. They confuse people. They lead to bad clinical decisions like, hey, let me throw gentamicin on everybody so I can get a Cidal effect. Okay, great. You just blew the patient's kidneys for a theory.
So let's think about, go to the clinical part that you just start mentioning. Because, I mean, these phenomena are, you can really get really nice studies in vitro, single cell. The other term that I had forgotten is heteroresistance, right? Which is also an interesting one that, from the clinical point of view, I think, and I've said that several times, that when you use an antibiotic against a bug, you are going to have heteroresistance no matter what with any antibiotic. Because bacteria are not stupid, they are really very well evolved, and these genetic changes are very interesting. So yeah, they are cool phenomenon probably, and we're learning more about it. But what is the applicability? But I just want to move to what does it mean for people who use antibiotics?
Yeah.
So I remember me telling me in medical school, if you have endocarditis, you have to use a bactericidal antibiotic.
Yep.
What do you think about that?
Okay, so first point. Every single antibiotic on the market today kills bacteria. There are no antibiotics that magically inhibit cell division without killing the bacteria. That does not exist. You got to wipe that out of your mind. And that explains why When we systematically reviewed the literature, in 2018, there were 56 trials. There are now 60 randomized controlled trials comparing, quote, static agents to Cidal agents head-to-head across a variety of very serious types of infections. And out of the 60, 53 found no difference in efficacy. 6 found the static agent was superior in efficacy to the Cidal, that was linezolid, beating the glycopeptides. And only 1, the tigecycline VAP trial, found the static agent inferior. And in that trial, they underdosed tigecycline. They did not hit their PK/PD targets. And when they repeated that trial with the higher dose of tigecycline, it was now not inferior to the carbapenem. There is no clinical relevance to static Cidal. Now, you're correct, Cesar. One of the holdouts has been endocarditis and meningitis. And the reason for that is that in the 50s, doxycycline, or actually it was tetracycline, the original, the macrolides, erythromycin, and sulfa, not trimsulfa, sulfamono, all did poorly against endocarditis, and they're all static antibiotics. So people say, oh, well, you can't use static antibiotics for endocarditis. Okay, let's take a really close look at this. The tetracyclines and the macrolides have massive volumes of distribution. They achieve horrible levels in blood. They leave the bloodstream immediately and enter tissues. Why would they work for a high-grade bloodstream infection when you can't get them into blood at a high enough concentration? Sulfa has higher concentrations, but terrible MICs. So the real issue here is PK/PD. It's not static Cidal. These are drugs that are PK/PD not optimized for an endovascular infection.
Okay, so that's a very important point. So I'm going to try to be a little bit controversial here.
Okay.
So my favorite bug that I've been studying for the last 24 years is enterococci.
Okay.
And you know, if you take a streptococci and enterococci and you give them penicillin, and you achieve the PK/PD targets, and even if you put it in an animal model, which we've done, and you give it a betalactan, which is supposed to be susceptible, the rate of killing between these two is very different.
Mm-hmm.
The MIC is different, right? But if you add an aminoglycoside, for example, the rate of killing increases significantly, right? And I think the clinical data, you are correct, the clinical data to support that is not really there. And I don't think anybody is going to do a trial on this anymore. But it is clear that at least the rates in the 70s, and the rates of success of enterococcal endocarditis was much lower than in streptococci if you use a betalactam alone.
Yes.
And, you know, very prominent people who I consider my mentor. And by the way, today is actually European Barbara Murray's birthday today. And her mentor, Dr. Mullering, had these studies, and he showed mechanistically how these antibiotics help. So the combination, at least that, and it was called, is bactericidal versus the monotherapy with the betalactam that was considered static. What do you think about that?
And I think that that's exactly right. We know for sure that ampicillin ceftriaxone is non-inferior to ampicillin gentamicin. And so people have switched to amp ceftriaxone, which is a good thing because you avoid the nephrotoxicity. The challenge is no one ever showed that amp and gent clinically resulted in superior cure or mortality than amp alone. Now look, if you're going to use ceftriaxone, knock yourself out. It's virtually non-toxic. It's inexpensive. It's once per day. Great. But I don't think we should be putting people into renal failure over a theory. If you want to use a toxic agent because it's Cidal, show me some clinical data that it's superior. I think that's the challenge. I don't think we know the optimal treatment because the trial hasn't been done. But I will point out there's multiple studies with other organisms like staph showing more rapid kill agents are not clinically more effective than agents that kill slower for staph. So I think we have to be careful presuming there's a clinical outcome difference. And again, if you're going to use ceftriaxone, who cares? It's safe. It's not going to hurt people. But if it's going to lead people to use gent, that's bad.
And mechanistically, that's an interesting combination, for example, that that comes from also from the 80s, Loran Goodman labs, where this double beta-lactam combination that saturates different PVPs is a good strategy to kill better. And I think you're right. We shouldn't say it's bactericidal or static, but it does kill better. And this is something that now we are seeing now in the gram negatives, right? These new beta-lactamase inhibitors that also have PVP activity that saturate different PVP and kill better. But I want to go back to that linezolid things. I have used linezolid in CNS infections and in meningitis.
Yes.
And patients have done well.
Of course.
Right? So, so what, for example, meningitis is another example.
There are so many examples. Like when I was in training back in the day when I used to ride a brontosaurus to work in the morning because it was that long ago, we were taught to give amp and gent for listeria meningitis because you got to kill the listeria. Okay, gent doesn't get into the CSF, people. What the hell are you doing? You're putting people into renal failure for a nonsense theory that makes no sense. How about using some Bactrim, which actually gets into the CSF? Linezolid's a static agent. It gets everywhere. It has phenomenal penetration in the CSF. The static Cidal thing was making people make crazy decisions. PKPD, basic pharmacology, is much more important than this mythical theory of static versus Cidal.
That is absolutely clear. So how we can transmit this to clinicians? How do you get this idea of people of keep talking about bacteriostatic? What do you think would be the best strategy to do it?
Well, it's like a lot of other things in stewardship and stuff. There's no one means to get people to change their practice, but I think conversations like this, I like to use the analogy of the movie Finding Nemo. Remember, Dory keeps saying, just keep swimming, just keep swimming. We just keep talking about it, keep writing about it. Eventually, the culture will shift.
Yeah. So an important point that I want to make in terms of mechanistic studies, I do believe that we need to continue to provide basic science studies in this antibiotic action. But I put the example of the heteroresistant thing. And I know, Brad, did you remember this big deal with the Visa strains, right? And the vancomycin MICs, right? That if you have a vancomycin MIC of 2, you shouldn't use vancomycin anymore. That all the strains are going to do this, right? So in reality, the clinicians always want to see a test that tells you, do this, do that. And sometimes they don't want to think too much about it, right? So in terms of testing and developing some sort of strategies to differentiate these things, what are we missing?
I think that we need to be really, I agree, mechanism is important to align with clinical outcome. It explains the outcome. We have to be very careful not to presume, just because a basic science observation is made, that means it's going to translate into a clinical effect. So, as an example, again, as alluded to, in multiple disease entities with multiple pathogens and multiple antibiotics, killing the microbe faster has not resulted in superior clinical cure. There's multiple scenarios in which that's been tested. So you say, all right, well, that's no longer the thing we should focus on. Now let's focus on something else. I will tell you in multiple examples, PKPD has correlated with clinical outcomes. So we have to find the basic mechanisms that translate into clinical impact. And until those are linked, it's fine if you don't know. If the clinical trial hasn't been done, it's fine to practice based on the basic mechanism, but don't lock it in as like fact. It's theory, so that you can change your practice when new studies come out.
Very important things that you've said there. A group of patients that I always hear that you should use bactericidal antibiotics are those that are severely immunocompromised, which we tend to see very frequently, particularly, for example, in neutropenic patients. So and I think the concept is also confused because, I mean, this when antibiotics started to be used, in the early 50s, you just give an antibiotic and there was cure, particularly because you can alter the bacteria a little bit and the immune system will take care of it potentially, right?
Yeah.
And as you said, you don't need to give the huge doses. You don't need to give it for 30 days. You just give something correctly, and you will treat the infection. But in this patient, particularly people who treat immunocompromised patients, I'm talking about the neutropenic patients particularly,
Yep.
tend to think a lot about these concepts because
Yes.
there is no immune system.
And I wish they wouldn't. And it's not that their thinking is wrong, it's that their understanding of static and cidal is wrong. So, yes, you're putting a greater requirement on the antibiotic to do more killing in a person whose immune system is not so much able to help you clear the rest of the bacteria. But it turns out, let's look at linezolid. It's going to kill fine. Linezolid kills back to this idea that it's static, it's not going to kill, is not true. All of these static antibiotics kill bacteria. The question is, what gets to the site of infection better? Vanco kills faster than linezolid. Which one gets into the lung better? Linezolid. Which one gets into the CSF better? Linezolid. You need to put the drug where the bug is. The idea that I should use a, quote, Cidal antibiotic that doesn't get into the tissue well, let's look at daptomycin. It kills us faster than anything. You're going to use that for pneumonia in a neutropenic patient? It's inactivated by surfactant. We're asking the wrong question. Let's use fundamental PK. Let's get the drug to where the bug is at a high enough concentration to kill the bug and not worry about whether we label the drug static or cidal.
Wonderful. And in terms of clinical studies, so I am thinking about that we need to rethink about how to do clinical trials on new antibiotics. And that category of a static cidal, which is even included in the product description, is probably something very misleading, right? So if you were to advise a pharmaceutical company in test an antibiotic, I know what you're going to answer, but was the PK/PD very important and the most important, and what kind of a studies you should do before you put it in a human?
Yeah, I mean, I think Dapto is a great example of how not to do it, right? Cubis wanted Dapto to be used for everything. So they did 2 pivotal phase 3 trials, probably cost $50 million, of community-acquired pneumonia, having never studied Dapto in a pneumonia animal model. Oops. That's when they learned it didn't work for pneumonia, went back to the mouse model and discovered surfactant inactivates it. Oops. Might have been nice to know that, right? So yes,
You are in the control group, on the Dapto group.
exactly. So I mean, I really do think there's a lot of literature. It's not that PK/PD is perfect in every case, but there's enough clinical examples where it predicts that you want to optimize getting the drug to where the bug is at a concentration high enough to inhibit the growth, and with the unique twists of, is there a tissue-specific problem? Aminoglycosides don't work in an acidic environment. Don't use them for an abscess. Dapto doesn't work in the lung. There are some unique twists you just have to look out for during development.
So, and the challenge, so I want to hear your opinion about the challenge of the untreatable infection, right? So that we're seeing more and more, particularly with these gram-negative organisms, where, data, limited clinical data suggests combination therapy to achieve better killing is good. What are your thoughts about combination therapy to achieve better killing once you optimize those PK/PD parameters?
Yeah, I think combination therapy has a role, but it's not to increase killing, because I think we've done that and it hasn't worked. I mean, how many trials of dual therapy for Pseudomonas are out there that all failed? I mean, it's been meta-analyzed. You don't need 2 drugs. I think what 2 drugs do is it broadens the spectrum of activity. So if your first drug if it's resistant to your first drug, you have a second drug there just in case. And then there may be, like, colistin just isn't very good. It just doesn't work very well. And so you add a second agent to colistin just to try to enhance, just because colistin isn't very good. For rifampin, you're going to get resistance to it emerge pretty quickly. The second drug is there to protect the rifampin against resistance. So it's not that two drugs is always wrong. Just do it for a rational reason. And making the killing go faster does not translate into better clinical outcomes.
And at the end of the day, what you want is really to kill the organism. And I go back to the enterococci, which for me is a poster child because they are inherently resistant to many of these drugs. Interestingly, I still hear people who want to use aminoglycoside for enterococci alone, right? When you see the MICs are probably 1,000 or more because they are really resistant to these organisms. And the only way to use aminoglycoside is in this combination. But mechanistically, and particularly, I want to get back into this different mechanistic impact. So with these new beta-lactamase inhibitors, what we are now seeing a different effect that just inhibiting the beta-lactamase. And then combination of more than one beta-lactam becomes really powerful against these organisms, at least in the animal models, and of course in vitro. And that opens new mechanistic possibilities. So I want your comments into prevented resistance, that you mentioned that.
Yeah.
Particularly mutations in certain PVPs that we know are selecting. And now that we have choices, for example, for gram-negative, what do you think about thinking about those choices from the beginning to avoid developing resistance later on?
Yeah, I mean, this is it's a great question. It's a debate I used to have with poor George Strusano all the time. May he rest in peace. He was a wonderful dude. And George and I were on opposite sides of this. So I think that it is rational to do if there is a uniquely high rate of emergence of resistance on therapy. So TB, for example, you use monotherapy INH, it's going to get resistant, almost certainly. But that's not most pathogens and most antibiotics. And my concern is if you're going to generally use two drugs to prevent resistance to one, both drugs are going to be in the microbiome and it get excreted into the environment. And yet, for that one patient in that one moment, you may decrease the emergence of resistance, but you're going to increase the emergence of resistance to both drugs in the environment at a much more rapid rate. So I think we have to be really careful to do that very selectively. Acinetobacter emerges resistance on therapy, famously. Most bacteria don't. And what we're worried more about is emergence of resistance off target that may later cause a relapse. Two drugs are not going to work for that. You're going to excrete metabolic breakdown products of those antibiotics into the environment and select for resistance in the environment. We have to be really careful with this strategy.
Okay. And the last point I want you to comment, you just mentioned about the microbiome and this selection of resistance. That every time you give an antibiotic, particularly with this particular spectrum, including anaerobic spectrum, and the famous combination of piptazo for everything, right? It's going to produce an effect in your gut bacteria. Because every time you expose bacteria to antibiotics, they are going to change. They are going to respond. So I've been more careful now thinking about, do I need an aerobic spectrum and antibiotics in this patient? Why would you use that for pneumonia, for example, right? Why would you use piptazo for pneumonia? People say, well, this is aspiration pneumonia. Well, that's very controversial that you have to use anaerobic or antibiotics for that. So what are your thoughts on that relationship between antibiotics and microbiome?
No, I completely agree. We need to be in this for the long game, right? We're only 85 years into the antibiotic era, and we've already burned through antibiotics 3 separate times and had to go back to the drawing board and beg pharma to come out with new stuff. Well, what's going to look like 500 years from now? We need to become much better at this, and that means treating only when necessary with the necessary agents and avoiding overbroad stuff We have got to decrease our selection of resistance or these things are not going to last.
Well, with that, I want to thank Dr. Spellberg for this wonderful conversation. I hope you guys enjoyed this conversation. And this is a controversial but very important topic that we wanted to broaden. And I want to remember to see you, all of you, in Las Vegas in Imari. This is Cesar Arias, Editor-in-Chief of AAC, signing off.